Hi everyone, thank you for joining. I'm just going to give it about a minute to let everyone sort of filter in as they join the webinar, and then I will kick it all off. So hopefully the numbers go up soon and we can start talking to our excellent lineup of speakers today. All right, I can see that the numbers are coming in, so I will kick it all off for us. Hello everyone, and welcome to our webinar today looking at Oxford Health's interoperability journey with Innovacom. For those of you who don't know me already, I'm Andrea Downey and I'm Senior Reporter here at Digital Health. I'm your chair for today's webinar, but don't worry, I'm leaving the discussion about interoperability and how best to achieve it to the actual experts. In the next hour, you're going to hear all about Oxford Health's work with Innovacom to join up services in the area, including enabling urgent care services to access the Oxfordshire Shared Care Record and also integrating care notes into pharmacy services. We have 4 excellent speakers for you today, including Chris Walkling, who is Senior Digital Programme Manager at Oxford Health NHS Foundation Trust, Alison Caulfield, who is Head of Clinical Systems at the Trust, Fatty Saad, who is Systems Integration Manager at the Trust, and Mark Smith, who is Business Development Director in the UK for Innovacom. Glad I got through all of those names without making a mistake there. I will shortly be handing the reins over to our guests, but very quickly, just before I do, I wanted to remind you that we will have a Q&A session at the end of the presentation where you can put your questions to our panel. There will also be 2 polls during the presentation, so keep your eyes open for those and answer them as they come through. If you do have any questions for our panel at any point during the webinar, you can submit them at the Q&A section at the bottom of your screen, and I promise I'll do my absolute best to get to them at the end. My only demand is that you tell me who they're for so I know who to ask them of. That's it from me for now. I'm going to be handing over to Alison.
Thank you, Andrea. So Chris, Fatty and I are going to talk through Oxford Health NHS Foundation Trust's interoperability journey today. So we're going to cover the Trust digital strategy, our interoperability journey and future vision. Then we'll focus on some case studies and hear some feedback from clinicians about some of the benefits that they have experienced. We'll have a look at the technology used and reflect on our journey around what went well, finishing up with some questions. So I'm going to hand over to Chris, who's going to talk.
Thanks, Ali, and hello, everybody. So as Andrea said, my name's Chris Walkling, and I'm the Senior Digital Programme Manager at Oxford Health. And I'm going to briefly provide some background on the Trust and our overarching digital ambitions, and then I'll hand back to Ali and Fatty, who will take you into the detail. So by way of background, Oxford Health employs 6,500 people. We deliver a wide variety of community and buildings-based services, and we also have a wide geographical footprint. So we deliver in 4 counties and across 2 integrated care systems. In terms of provision, we provide community services for adults and children, from health visiting to GP out of hours. We provide all-age mental health services, and in addition to mainstream services, we also lead a number of provider collaboratives for ED, forensics and Tier 4 CAMS. We provide urgent and emergency care and community dentistry. And in terms of strategic context, in common with, I would think, most people on this call, we have a number of external drivers that have shaped our approach to digital. So notably the 5-year forward view, the long-term plan, the NHS People Plan, and most recently NHSX is what good looks like. And these external drivers are then articulated in our own internal strategies. In terms of the slide that you can see in the key highlights, we have an overarching corporate strategy, which takes us from now to 2026. That was agreed in April. And this really articulates our vision of outstanding care delivered by an outstanding team. And throughout that strategy, digital recurs again and again as a critical enabler for us in terms of delivering our overall ambitions. And then we also have a specific digital health and care strategy, which we agreed in July 21. And as you can see, this is based around 4 key themes. So we have digital empowerment. This is predominantly about patient-facing technologies. So how we're improving access to digital health and care for people who use our services. That includes things like virtual consultations, apps and devices, and remote monitoring, and the personal health record. Digital culture is very much about how we support our staff around digital. So it's about improving our mobile and flexible working capability, about our digital care pathways and decision support tools, and also about the whole area of digital leadership, learning and development really across the organisation. Digital foundation is fairly self-explanatory. Like everyone on this call, having a secure and reliable infrastructure is really critical to our business, and also having clinical systems that are fit for purpose. And lastly, research and collaboration, which is a key priority for us as an organisation. We're very focused on our continual development of national and international partnerships. We have a number of interesting projects running at the moment with colleagues at Oxford University around advanced analytics and AI. And we're also increasingly contributing to population health management, both at place and across the ICS. And as we'll go into more detail around, interoperability really is our kind of transformational foundation for delivering the majority of our digital aspirations. In terms of where we've come from, we're one of 7 mental health GDE trusts. That programme helped us deliver 22 distinct and varied projects, ranging from VR therapy pilots to EPMA. And we had 3 projects which focused specifically on expanding EPR capability and another 6 on enabling infrastructure. And taken in the round, GDE has been a real key enabler for us in terms of developing our integration work to date. Looking to the future, our focus is very much on integration across services, organisations and systems. And all of those developments are really underpinned by the flow of information across health and social care providers and with the people who use our services. And I hand back to Ali, who's going to describe our journey in more detail. Thank you.
Thank you, Chris. So we've heard from Chris about our Trust digital strategy, and we can see from this that interoperability is key to delivering the elements of the digital strategy. For example, a single patient record for the Trust requires integrating the clinical data from the disparate sources. Using apps and wearables to support care delivery requires integrating the data with core clinical data to present the clinician with an overview of the patient. A best-of-breed approach to clinical systems requires integrating clinical information to prevent clinical teams working in data silos. Record once, use many times. This principle ensures the right patient information is shared as required to support patient care. It provides clinical efficiencies and a better patient experience. To become a leader in research, aggregated data is key, as it is for data-rich clinical decisions. To implement patient and clinical portals, clinical data from across all sources needs to be available to view as needed to support care delivery. So time and time again, having the ability to integrate information is a key digital enabler and a launchpad for further innovation. So I'm now going to talk through an overview of our interoperability journey, and then we're going to discuss some of the projects in a bit more detail. So 2018 was the start of Oxford Health's interoperability journey with the procurement of the Innovacom Trust Integration Engine and the start of our proof of concept project. Delivered 2 aspects of the proof of concept project. These were the export of data from the Trust's core electronic patient record system, which is Care Notes, to the Child Health Information Service, and the import of some of their data back into Oxford Health and disseminated to the relevant teams for consumption. And the second being the implementation of the automatic sending of the interim discharge summaries for mental health inpatient wards directly from Care Notes via DocMan and the integration engine to the relevant GP practice. 2020 brought further interoperability between systems, including Care Notes and Ascribe, which is our Trust's pharmacy stock control and dispensing system, where patient demographic and episodic data is shared. COVID pressures also fast-tracked the Bucks Shared Care Record, and Oxford Health implemented a mental health data feed into this via the integration engine early in 2020. Other 2020 interoperability milestones include dissemination of immunisation data to relevant health visitor teams and GP practices via the integration engine, and also a pilot funded by NHS Digital for transfers of care, first of type work for structured messaging for mental health discharge summaries. Again, COVID pressures have fast-tracked the Oxfordshire Shared Care Record, with contextual links added to the Trust's core clinical systems earlier this year to access acute and GP information. And the addition of the Oxford Health dataset is underway. This year has brought some exciting developments with the implementation of a suite of Care Notes APIs, facilitating integration of real-time data with the Trust's core clinical system and other systems such as True Colours, which is the Trust's app for collecting PROMs, and also between Care Notes clinician diaries and Outlook, and also with BetterMeds, the Trust's EPMA solution. And finally, to our vision, which is a clinical data layer held in the cloud, fed from our clinical systems via the integration engine, and then the required real-time data set can be viewed by the clinician via a clinical portal on any device in any location. And this slide just develops that vision a little bit further into the clinical system strategy and highlights some of the key principles. So the best of breed approach to clinical systems results in a larger number of proprietary systems, and potentially some apps and e-forms may be developed in-house to support specific functionality required. All clinical data is input into these core systems, e-forms, apps on any device in any location. And then the clinical data flows into the clinical data layer, forming a single source of the truth. Clinicians can then consume this data via a portal. They can view the cut of data they need for the job in hand on a device that they choose in the location that they're giving the care, such as the patient's home or a clinic. All clinical data output external to the Trust can then flow from this data layer. For example, our shared care record feeds. The clinical data layer can also be used for research, analytics, intelligence, and it can be scaled up and down for use cases across wider health settings. So I'm now going to hand over to Fatih to talk through the technical architecture that underpins the clinical system strategy.
Thank you, Ali. Hi, everyone. I'm Dr. Fatih Saad. I'm the Systems Integration Manager. As Ali's mentioned, that the Trust has adopted the best of breed strategy. And in order to make this strategy work, there is a lot of integration behind the scene to make sure there is a seamless information exchange between those best of breed systems for internal and external systems. So as you can see here from this high level design, the purple layer, this is the integration engine, which constantly look for information from the best of breed internal clinical system and external, and make those data available for to other clinicians, and also incorporate all this data in an integrated clinical data repository, which later will be used by clinicians across the services. It's worth mentioning that the blue layer, which is the clinical data repository, now become the single version of the tool for all the data coming from internal and external data sources, and also will be shared with external sources as well. Over to you, Ali.
Okay, Fabiana, can you please launch the poll? So I think we're hoping that everybody will complete the poll, and then we're going to share the results in a few seconds. Okay, thank you. So that shows us that the best of breed approach has got 50% of our votes, single system or solution 5%, and not sure 45%. So that's really interesting. Thank you. Okay, so now we're going to move on to some specific case studies, starting with the interim discharge summary. So this is a form in Care Notes used in mental health inpatient wards to summarise patient information, discharge details, medication diagnosis, discharge plans, and it's shared with the GP on discharge. And this form was developed jointly by trust clinicians and GPs to ensure it contains all of the relevant and appropriate information. And how it works is the clinician enters the patient information into the form in Care Notes and then saves the form. And this then is automatically sent to the relevant GP practice via DocMan and the integration engine, where it appears in the GP's EPR system, providing a standard method of delivery and alleviating the need for any manual handover of information. Previously, this would have been done manually, and an estimated of 380 hours of clinical time has been saved by this automated integration work. Over 4,000 discharge summaries have been sent in this way to date, and currently we're sending about 1,000 a year. Any rejections are monitored centrally by our clinical applications support team as part of their business as usual activities. And we've had some feedback from Dr. Kosler about this, and he says, he's our clinical director, and he says, it gets sent within 24 hours to the GP seamlessly via DocMan with up-to-date medication and diagnosis. This is really important to ensure the GP has all relevant information immediately after discharge. The summary is easy to read and gives a brief summary about circumstances leading up to admission. So I'm now going to hand over to Fatty, who's going to talk through the transfers of care case study.
The transfer of care is a national initiative that is introduced by NHS Digital in order to ensure that key clinical document that shared between NHS healthcare organization in a timely and secure fashion. So the aim of, or the benefit from this transfer of care initiative is to improve the patient care and the safety due to the availability of completeness and accurate information. And this information will be shared in a timely fashion with other NHS organizations. It also reduces the risk of missing and incorporate critical clinical information, because all the data or the data source behind the scene that have lots of sort of validation put in place in order to comply with the validation that introduced by the transfer of care validation protocols. It also reduces the cost, because now we're moving from a traditional way of sending documents between NHS organizations to an electronic form, which that happen electronically without any manual intervention. So currently in Oxford Health, that we have 4 GP practices that we are using for the first type testing for the end-to-end proof of concept. And that resulted in 36 discharge summaries shared with our practices through the MESH, which is the message exchange of social and healthcare data. It's worth mentioning Oxford Health is the very first mental health trust to be awarded the transfer of care certificate for system providers. And we are working with NHS Digital in order to verify the compliance of the ITGP system suppliers like EMS and TPP for their compliance at the receiver of the messages and process them appropriately. So we do have a quote here from Dr. Mike Moore from the NHS Digital. He is a digital program manager for this. And he said that Oxford Health have not only played a significant part in testing with GP IT system in a non-live environment, but also made a critical contribution to reaching the deployment verification criteria for first of type work carried out in the live environment with real patient hospital event and essential information transfer for their practices. So the next slide here, it shows the high-level architecture behind the scene in order to enable all that flow of information between the suppliers or the senders and receivers. So the blue box, this is the Oxford Health, the integration engine, the TIE, always look for a discharge summary that for newly discharged patient, and then electronically and automatically generate the report and then send the data into NHS Digital to the mesh server. The mesh server then validate the message to make sure that all the key information, they are actually valid and included in the message. The next step will be to look up for the practices to see which is the right practice should need or should have this information. And then it automatically route that message to the right practice. Then the practice, they will receive the message, validate the content, and apply business logic. And then they pass all the validation, then they automatically file that document against the patient record. If for whatever reason, if that document failed the validation, then we do have an acknowledge back from the supplier or from the practice to tell us what went wrong so that we rectify the issue and resend the document again to ensure that clinical information reach the clinical system in timely and secure fashion. Over to you, Ali.
Thank you, Fatih. So I'm going to talk about another case study, which is our Care Notes and True Colours integration. So as I mentioned earlier, True Colours is an online self-management system using questionnaires to create a record about how a patient's feeling and how this changes over time. And it's used by our CAMS service for outcome monitoring. And patient and demographic and episodic data from Care Notes has now been integrated into True Colours. And so in the short video to follow, we hear from Dr. Rousel, who's head of psychological therapists for CAMS and a consultant clinical psychologist. And she's going to describe some of the benefits of the Care Notes to True Colours integration.
Hi, my name is Eleanor Rousel and I'm the Head of Psychological Therapies for Buckinghamshire CAMS, and I work as a clinical psychologist in Buckinghamshire with children and adolescents. I've been asked to describe how the Care Notes to True Colours integration has benefited us in CAMS. As one of the clinical leads involved in the original development of True Colours, and as non-techie people, we really did not appreciate the huge issues that creating a separate system would bring. I think that the lack of ability to link caseloads with Care Notes was probably the single biggest factor which resulted in us stopping using True Colours. Clinically, True Colours worked really well and young people loved seeing their results, and particularly the graphs straight away. I think previously we had to rely on admin to put on both the demographic information and keep updating our True Colours caseloads. This was not only extremely time consuming, but also could not be done quickly enough to respond to clinical needs at times. So, for example, if I was to pick up a case urgently, it was yet another thing to remember to ask admin to put them onto my True Colours caseload and persuade admin to prioritise doing that urgently. There were also huge issues with clients being open across various pathways and not being able to represent that on True Colours. Our admin team were really not very positive about True Colours due to the amount of time it took them. Likewise, clinicians also got frustrated due to the amount of time it took them chasing admin and waiting for things to be updated. There were issues with young people not being discharged, so our True Colours caseloads became unwieldy, making it really hard to find what was needed. It's early days for us in terms of relaunching True Colours. Talking to clinicians and managers, one of the first questions they ask is whether they will be able to see True Colours data in Care Notes. But having up-to-date caseloads in True Colours will hopefully help us to re-engage all our staff in improving our collection and use of routine outcome monitoring.
So that was Dr. Eleanor Rousel, and just talking about some of the benefits that the CAMS service have experienced, including real-time, reducing time, manually inputting the patient information, ensuring the caseloads are up to date, responding to urgent care pathways, and supporting multiple episodes of care. So now we're going to move on to another case study, which is looking at the Oxfordshire Shared Care Record. And this is based on the Cerner platform, and it's referred locally as the HIE, and it's referred to as the HIE in the short video that we're going to play in a minute. COVID fast-tracked the go live of this platform, sharing the acute and GP information initially, and it provides access to critical patient information, for example, results like blood results, radiology results, discharge summaries, admission and outpatient appointment data. Access is via contextual links within our patient records and also other organisations' EPR systems. Oxford Health data is now being added to the platform. So we're adding a mental health data set, community health data set, and an urgent care data set. And then Oxfordshire County Council and Berkshire NHS Foundation Trust data will follow on from this. Urgent care clinicians have accessed the HIE over 700 times a month since it went live. And in the short video to follow, we hear from Dr. Neil, who's a medical advisor within our Oxfordshire Urgent Care Service. And he's talking about how HIE has benefited directly urgent care clinicians, including accessing discharge letters and medications to make clinically informed decisions and interpreting pathology results out of hours with access to discharge information.
My name is Ian Neal. I work as an out-of-hours GP in Oxfordshire. I just wanted to say how valuable I found HIE Cerner from the point of view of an out-of-hours GP, the ability to access information from the John Radcliffe database has been very important to me in my work. For example, patients often contact us requesting opiate medication, saying they've been sent with insufficient when they've been discharged home from the John Radcliffe. By being able to rapidly access the John Radcliffe discharge letter, I can read the discharge diagnosis, for example, renal stone, find out what medication has been given to the patient and at what dose and how much, and then make a clinically informed decision as to whether to give them more medication, such as tramadol in the case I'm thinking of, or whether to politely decline this because it's been already prescribed in sufficient quantity. I've also been able to use it to interpret those rather awkward pathology results we get on Saturday mornings, which the GPs have taken on a Friday afternoon. And we, of course, have no information about the patient at all. Recently, I was able to assess the severity and concern I should consider for an elevated potassium and work out precisely the long list of complex diagnoses that the patient had on his recent discharge, which had not been uploaded yet by the GP, and again make an appropriate clinical decision. Thank you.
So moving on to another case study around care notes and Describe integration. As I've previously mentioned, Describe is our pharmacy dispensing and stock control system. And previously, the pharmacy team had to manually transcribe patient information from care notes. Now, patient demographic and episodic data is integrated from care notes directly into Describe, negating the need for the manual inputting. It was part of our proof of concept project for the integration engine. And we baselined some of the existing processes over a month. And there were 861 patient admissions, transfers and discharges, which took the pharmacy team 34 hours to process in Describe. And we extrapolated this for a year, taking us to 408 hours which equated to just over £9,000 savings made. We completed as-is and to-be processes with the pharmacy team to support the change in ways of working needed. And some added benefits were also reducing transcription errors, reducing duplicate patients, and fast access to information. So I'm going to hand over to Fatty now to talk through our Care Notes, EPMA and Ascribe integration.
Thank you, Ali. So the Trust recently procured electronic prescribing and medicine management system. And we do have a requirement now to make the data that happen within the clinical system. It is electronically and automatically shared with our EPMA solution. To achieve this, we had to integrate patient information as soon as the patient register or a patient get demographics updated. This information automatically shared with the EPMA system. Also, if there is any new admission to the ward, any transfer between the wards, or patient went on leave or patient get discharged, we need to update the EPMA system with all those changes happen within our clinical system. Additionally, the staff who are accessing the EPMA, they need to have the same permission that they have now within our clinical system. For example, if a patient, if staff that is disabled from using our clinical system, that automatically that will be shared with the EPMA, and automatically that will be disabled from accessing the clinical system. So now this is in the final UAT testing, and soon we're going to start the end-to-end solution, which will put all this information in practice with the help of our clinician. Thank you. Over to you, Ali.
Thank you, Fatty. So we've got another short video now where Lex Moon, who's an advanced perinatal specialist and our lead EPMA pharmacist, is going to talk through the benefits of the Care Notes, Ascribe and EPMA integration for the pharmacy team.
As a pharmacist working within the pharmacy team, I've noticed a number of benefits since the integration of the systems within the Trust. One integration we've seen within pharmacy is an integration between Care Notes and Ascribe, which is our in-house dispensing system. We've noticed that since that has occurred, we've seen a reduction in transcriptional errors when patients are admitted to the hospital. We used to have to update the Ascribe manually every time a patient was admitted, and that meant that each patient had to be added by hand every time there was an admission that hadn't already been into us. However, this sometimes led to transcriptional errors on admission, and that then led to potentially more than one entry for the patient on the system. Now with the Care Notes and Ascribe integration, we're being able to have patients manually automatically added to Ascribe as soon as they're added onto Care Notes, and this is reducing the number of multiple entries for patients. There's also sort of a potential cost saving there in that when patients are moved from one ward to the other, they are being able to be updated automatically on Ascribe, and then when we're dispensing, the medications are definitely being sent to the correct ward. Care Notes tends to be updated fairly regularly when patients are moved, but drug charts, it can often be missed, and so having this integration helps to get the medicines to the right place, meaning that they're not wasted or sent to the ward where they would sit in a cupboard and not necessarily be used. In my role as well as the EPMA lead pharmacist, we've also looked at integration in terms of obviously Care Notes and the new EPMA system, and also potential future integration between the EPMA system and our dispensing system in pharmacy. This is potentially beneficial on a number of levels, because this means that we again can reduce the number of transcriptional errors we have between the different records that we keep for patients, and help for the integration to update each of the other systems as well. What it'll also have a massive benefit for pharmacy is at the moment any information from drug chart to Ascribe has to be added manually. It also means that anytime we want to look at a drug chart, we have to have that scanned over to us. So it's taking a lot of time from nursing staff and from pharmacy staff. So the EPMA system being able to talk to us and to talk potentially to a scribe in care notes means that we can get that information far faster and far more reliably. In terms of out of hours and things like that, it's also fantastic. One other really good benefit with the integration between the systems is that we can finally get to a point of having one true source for information that is then shared across the systems. One good example for this is allergies, where you may enter different systems and have slightly different information on each system, which is not what you need. You need to have really clear allergy statuses for patients, and that needs to be the same on all of your platforms. Integration between these platforms will be really beneficial because that will allow us to do things like this. Other sort of integration possibilities are going to be things like admission and discharge, and being able to get the information from the patients and from their healthcare providers initially when they come into us, but also being able to produce clear and concise discharge summaries that will be recorded not only in the patient's notes, but also be able to send on to GPs and things like that, giving a really clear and concise information about their stay. And that will be able to be done automatically with links between the system. So all in all, yes, the integration between systems has been really beneficial as a clinician, and I can see it getting better with the implementation of EPMA as well.
Okay, so I'm going to hand over to Fatty now to talk through some of the technology that we've used.
Thank you, Ali. This slide, it just shows a diagram that shows the capability of the integration engine and the technologies being used to deliver various integration projects at the moment. So for example, we do have data coming from various sources like databases, like Logship databases, the APIs, some information we got it directly from Azure database, and also files shared with us through the secure FTP folders. We then process the data and share them in various standards to various destinations. There are so many standards used, like HL7 for the integration with pharmacy system. We use FHIR for the integration with the transfer of care and for the EPMA integration, SFTP that for sending data to other NHS organizations, such as the Commissioning Support Unit for the Care Plus for the child health information. We also send the data to various APIs in order to process the data in target systems. Also, we do share some data in a secure email, especially for practices, to include, for example, the immunization given to patients from children from the school settings, in order for the GP to update their record for those patients. So all in all, there are various standards being implemented. There are various data sources and data types that are implemented within the project that delivered so far. And it's worth mentioning the integration engine we use, it has zero code. It's everything user interfaces that contributed to the high productivity of the system integration team to deliver project in a very quick fashion. Thank you. Over to you, Ali.
Thank you. So I think we're going to have our second poll now. So Fabiana, are you able to launch that for us, please? Okay, thank you. So we can see the results on the screen. So it looks like the highest highest risk and priority is the shared care records, but closely followed by EPR and EPMA integration, with transfers of care quite down the bottom, in fact on 0%, which is interesting. So thank you everybody for that. So I'm going to now move on to what has worked well. So reflecting on our interoperability journey and what has gone well has been really useful. And here are a few of our key messages. So having clinical leads to support the transformation of the potential changes in processes and ways of working helps embed these processes and these changes and transition from project to operational ownership after go live. Mapping out the as-is and to-be processes with the clinicians highlights these transformational changes and draws out the benefits. Having the right level of clinical sponsor. Generally, we have CCIO and clinical director level sponsors, and this supports the engagement and clinical involvement. Ensuring good stakeholder engagement with robust comms and training plans. And we've used a variety of mechanisms and mediums. So we've used training videos, posters, newsletters, we've used the intranet, we've used emails, and roadshows, done sort of roadshows, joined various meetings and things. Having a low-code integration engine enables development to remain in-house and reduces supplier reliance and allows us to be agile and flexible and responsive. Baselining current work processes supports the benefits realisation, and we've tried to do this via analysis of data rather than asking clinicians to take more time out of their clinical work to complete forms and questionnaires. Ensuring operational business as usual processes are in place to support the clinical services with issues. For example, ensuring correct monitoring and alerting processes are in place with clear business continuity plans if needed. Ensuring the information governance lead is engaged and involved with the interoperability programme and the relevant assessments and agreements are completed. Ensuring the technical teams have shared knowledge and work in an agile methodology to prevent silo working and knowledge. And having the clinical safety officer as a key sign-off prior to go live, having been involved throughout the project, just a final clinical safety review is really useful. And finally, reflecting on the Trust's interoperability journey, this is just the start. The future is exciting, where interoperability will be inherent and not bespoke, unleashing the power of data to deliver Oxford Health's vision, outstanding care by an outstanding team. Thank you.
Thanks, Alison. That was really, really interesting. So I'll get straight onto the questions because we are running out of time quite quickly. That's gone fast. So the first question I would like to ask is kind of one directly to the Trust. So there's 4 of you that could answer. What have been the key challenges in your interoperability journey so far, and how have you actually managed to overcome them? I'm sure there are probably a few of them.
Yes, I think there's plenty here, but I think some of our key challenges looking over the last couple of years has certainly been around clinical input and involvement, especially during COVID, where services are so stretched at the moment. You know, for example, with our shared care records, there's so much clinical data available. It's identifying the critical clinical information to share as part of the shared care records requires that clinical input. I think other challenges at the start of our interoperability journey, not all suppliers had interoperability as key functionality within their systems, you know, but this is certainly a changing landscape, and we've seen a change over the last, year especially, and going forwards as well. And just a couple of others. I think at the start of our journey, you know, we didn't have an integration team, so we had to upskill our team to to enable us to embark on this journey. And we did this with Inovacom's support and with an internal subject matter experts. And this is an ongoing learning curve for us as well. And I think they're probably our key ones. Thank you.
Okay, so moving on from that, you in the webinar described Oxford Health's can never get that word right, interoperability journey and the visions that you have. So what are the next projects that you're going to be working on, and how are you going to be working within the Trust to achieve those?
I think I'm going to ask Fatty to answer that question.
Thank you, Ali. Yes, so there are some exciting projects coming, to be honest. And first is the digital observation. So we do have some wards, they do have cameras that constantly record observation. These are at the moment kept within the ward and never been shared with a wider services. So now our target is to make sure this data is shared with the rest of the clinician across the services. The second exciting project is to make use of the current blood system, which clinicians used to request and review results, because now at the moment they need to log into different systems to record and view this clinical information. So our challenge now is to use the integration in order to pull the data, integrate them in central location, and make them available to clinicians. Also, one of the key projects coming ahead is the building of the clinical repository, which will integrate all the data from the best of breed systems. And then we are going to implement an interface that will be accessed by clinicians to view in one view. They can see all the data for that patient across all the services from the local system as well as external systems.
Perfect. Thank you so much. So the next question is probably for both Oxford Health and Inovacom, because I think you've both obviously gone on this journey together. So I wanted to ask, how the partnership has been between the Trust and Inovacom and how it's evolved during this journey. Alison, I don't know if you wanted to take this one first, or if someone from Inovacom wanted to jump in.
Yeah, I think if it's all right with Mark, I'll start off and then hand over to him after. So obviously we selected Inovacom as our supplier of the integration engine for various reasons, but one of the key ones was the low code nature and the ability of the Trust to manage the integration in-house and not rely on the supplier input for every project that we wanted to work on. And part of the contract included training and upskilling of the team, which Inovacom delivered really well, and they've supported us on our journey all the way through. And as part of that, they've been part of our Trust Digital Strategy Board and supported and shared innovations as part of that, and also subsequently become our Trust GDE international partner, developing this innovation sharing, knowledge sharing further. Mark, I don't know if you want to add something.
Yeah, can everybody hear me okay? Yeah, good. Okay, so I'm just going to share my screen because it's just helpful to show everybody the details of the conversation we had. And I just want to reiterate what Alison said, really. I mean, when we first met the team in Oxford, they were very clear about their interoperability strategy and how to deliver that. And this was very much around a skills program to transfer that skill. They really wanted to do it very quickly. And actually it's led by them, so we will just be led by them in terms of what they want. And I think that's the key message around Inovacom's vision, is really to help organizations that when they need it, and then providing sort of parachuting people in when they need to do that. And that obviously, as already been said, is that it's not reliant on outside influences. So you provide the support to the internal teams, so that you don't have this concern, the challenges around different sort of timescales that maybe a vendor have versus what the Trust want to do. Now, of course, when Oxford, first approached us in terms of looking at being the client for them in terms of the integration engine, they took a leap of faith. Okay, and because of that, I think that we all agreed that the best way forward was to do a proof of concept. And it was specifically focused on 3 specific projects, which we delivered through the training. So there was the there was the opportunity to have those skills delivered as part of that training. And of course, what that does is it provides a low initial capital cost and reducing the cost of taking a project forward. That's the way that they wanted to work. And of course, then on the back of that, it provides solid evidence to support a full business case when you move forward. And for me, there is this win-win partnership. So as Alison said, we are the global international partner of Oxford Healthcare, and I intend to provide as much value as possible in terms of our own expertise and experience and technology, but also from organisations that are outside that. And I know that working with Chris in the future, we'll be looking to try to help support and understand how the market, how things move forward on their digital journey. Clearly, COVID was a big impact on everybody, but I think that the examples that you've shown show that the collaboration between us and the work that they did, in complete dedication in terms of doing things in a very difficult situation, provides a good example of that. And the ITK version 3.5 transfer of care example that we shared was particularly interesting and complex, and talking with NHS Digital and Fatty and the team and Alison. And then in the future, I think the collaboration opportunity is, as Chris alluded to at the very beginning in terms of the strategy, is trying to look at where value points are not necessarily in the country, they could be international. And I think there's a real opportunity of collaboration around collecting mental health data, looking at the comparisons of that data, seeing how treatment plans differ from each other, or there are some patterns as well.
Thank you so much, Mark. So obviously interoperability is a bit of a buzzword in the NHS. I think it's in every plan and every strategy document that I've ever read. So I wanted to talk about, how you go about developing interoperability in a trust, and then who you consider when you're working with others in realising the entire interoperability ambitions for the NHS, because obviously it's not just one trust that's doing it, it's everyone. So how do you go about that?
Yeah, so it's a really good question. And for me, I think the most important thing is that you choose an organisation that has healthcare in its DNA. And that's what Inovacom is. They've been working in healthcare and have an extremely high knowledge around the subject. But I think also it's really important to invest time to understand what's going on from a national perspective and looking at the NHS bigger picture, the digital objectives of willing to invest time and money, change and transform your roadmap and sort of monitoring that situation for the benefit of the customers. I think interoperability is a journey, okay, and that requires, I think, an experienced level of understanding from a vendor like us, because what we can do is we can pinpoint the things that are really important for an organization through their digital maturity index journey, and I think that's a key thing. I think also, you've got to have an extensive understanding of health messaging standards, like the evolving ITK version 3.5, CDA, etc. And you need to know what's going on in the market. So, in the future, we know the integrated care organisations are going to be mainstreamed. The NHS landscape is changing, which means that technology solutions need to change, or they need to rise to the challenge in terms of looking at those new opportunities around the demands that have been placed on our clients. So, and if you consider the latest NHS ambitions of gaining access to patients' data by looking at separating out the data layer from the application layer, which is what Fatty and Alison have spoke about earlier, there's a recognition that you need to look at solutions that are going to support that. So a data repository, a single data repository is a way forward for that. I think from discussions I've had with mental health care trust in particular, I think there's a preference to look at maybe an architecture that is not centralized, it's more of a localized repository, which will provide an opportunity of a contextual link to the actual data, because mental health care data, the patients, there are sensitive data that is potentially at risk, and you don't want to share that openly and externally. So I think a vendor that has that deeper knowledge of mental health, customers will know that they prefer that work, and I think that's tantamount to an organisation that immerses himself in the customer experience.
Yeah, definitely. Does anyone from the trust want to jump in about how this works with the ICS in sort of the bigger picture, or how you've been working with your partners.
Hi everybody, thank you. So I guess in terms of the question in relation to the ICS, I think we feel that because we have a track record of delivering a complex range of services, we're delivering services across a number of geographies in terms of counties, so place-based areas and across ICSs. That has given us some level of local digital maturity in terms of our approach to integration and interoperability. And I think really that gives us, particularly with our ongoing development of the data layer, kind of proof of concept, which we are now in discussion with our colleagues across the ICS at potential adoption. We are just at the early stages of developing an ICS strategy. And so I think we'll see how we can integrate this work into the development of that as we go forwards.
Lovely. We've got quite a few more questions actually to get through before the end. So we'll see if we can race through in the next 5 minutes. First of all, one person would like to know if medications and discharge notes that are accessible, if they're accessible, in coded format to inform the CDS. Now, I hope somebody understands what that means, because that's gone straight over my non-technical brain. Would someone from the Trust like to take that?
Sorry, I was in mute. So can you repeat the question again? Sorry.
They would like to know if medications and discharge note contents are accessible in a coded format to inform the CDS.
Yes, so the standard adopted is to use the SNOMED, although that one of the transformation work we're doing with our clinician at the moment is to make sure everything is SNOMED coded. But currently, our clinical system support ICD-10 codes, and we are now make those transform into SNOMED for future use with other systems, because, for example, the pharmacy system are also looking at changing their uses to SNOMED code to have that consistency. Given the recommendation by NHSD that as part of the Care Connect, that is the terminology standard every interoperability system that should support.
Okay, thank you very much. Next question is about how information flows through the system. So when information is updated in it, does it go both ways across the system so that it integrates with Care Notes as well? So if you're putting it into a scribe, does that then go back through to Care Notes and vice versa?
Okay, I can take that one. Yes, yes, it is both ways. Although currently our clinical system, it was a system that doesn't allow any write back, but fortunately now the new release of Care Note that is allow us now to have data out of Care Note, but also inject this information back to Care Note so that it will be shared with the current system within the same usual clinical system. Yeah, it is both ways here of information.
Perfect. Sounds very efficient and saving people time, which is what we're aiming for. The next question is about patient data, which is obviously a fun topic at all times in the NHS. Where is the actual processing of the patient data taking place? Is this in the cloud or is this at the edge locally? I think, Patty, that one might be for you as well.
Yes, I can take that question as well. So initially, we implemented our interoperability infrastructure on the premise. We connect with all our systems, but we found some limitation within the on-premise, and then we decided, okay, we're going to go for the cloud. So currently, our interoperability infrastructure for both the development, UAT, as well as live, it is in the cloud, and that way all the information. But it is, although it's in the cloud, but it's as an extension to our on-premise data center. So is exactly the same level of security applied to on-premise data center is also applied to the cloud. So it is a secure environment within the permission and rules applied by our IT guys.
Yeah. Lovely. And just finally, one last very quick question. We've got probably about a minute left. Are there any plans to share the knowledge that you've learned in this process with other trusts, which is obviously shared learning is important. So maybe, is that for Alison or Chris maybe?
Yes, sorry, I couldn't unmute myself. Yes, we are absolutely want to share our knowledge with other trusts. So we work closely with a number of other trusts, you know, a lot of them who've got Care Notes because we've got that kind of shared, sort of shared requirements, but and also with our GDE fast follower. But if anybody wants to reach out to us, we're very happy to share what we've done with other organisations, and openly share. We're not keeping anything to ourselves, so to the benefit of the NHS, obviously.
Lovely. Well, thank you very much. But that does bring us to 1:30, so I'm going to have to wrap it up there as our hour is done. Just wanted to finish off by saying a really big thank you to Chris, Alison, Patty and Mark. I found that really, really interesting, and I'm sure that all of our attendees did as well. And of course, to everyone who has tuned into the webinar, thanks for attending. If you're ever interested in coming to any of our other webinars or events, please head on over to our events section on our webpage at digitalhealth.net. That concludes today's webinar. Thank you so much for joining, and I hope you have a lovely rest of the day.
Thank you.